Hi, my name is Mintu Charakia, and on behalf of CME Outfitters, I'd like to welcome you and thank you for participating in this CMEO briefcase series titled Telemedicine for Non-Valvular AFib Management, Turning Bedside Manner into Webside Manner. This is the third episode in our three-part series of this briefcase discussion. Today, we'll be talking about how to engage patients in virtual shared decision-making with a focus on the decision to use anticoagulation for stroke prevention in patients with non-valvular AFib. I'm an associate professor of medicine and I direct the Stanford Center for Digital Health. I'm also a cardiac electrophysiologist and I do research on stroke prevention in AFib. I now want to turn it to our faculty and introduce them. First, I'd like to welcome Dr. Margot Savoy. Dr. Savoy is chair of the Department of Family and Community Medicine at the Lewis Katz School of Medicine at Temple University in Philadelphia. Margot, welcome.
Thank you.
Great to have you. I'd also like to welcome another colleague. This is Jeff Barnes, who is a cardiologist and an assistant professor of medicine and vascular medicine at the University of Michigan Health System. Dr. Barnes is also an expert on anticoagulation, stroke prevention, and risk assessment and decision-making. Jeff, welcome.
Thank you so much for having me.
Great to have you both. Let's start first by reviewing the learning objective for today's session, and that's to really utilize digital decision aids for patient education and shared decision-making, really with a focus on doing so when providing care via telemedicine, which all of us, of course, are doing more of these days. I'd like to start by asking Dr. Savoy to present a case.
Thanks so much, Mintu. In our previous episodes, we met Mrs. Carter. You'll remember she's the 67-year-old woman with hypertension whose first indication that she may be having AFib was a notification on her smartwatch. So we ordered Holter monitoring and found out that she did in fact have AFib and discussed how this increased her risk of stroke. So what we need to do is start her on an anticoagulant. Today, I want to show you the conversation I had with Mrs. Carter in a follow-up telehealth visit. Do you have any questions or concerns about your medications?
Well, I'm still taking the blood pressure and the cholesterol medicine that I've been on for a while now. But that new blood thinner you sent in the prescription for, I haven't taken that because I haven't noticed the flutter feeling as much lately. And I heard at church about someone who took a blood thinner and had a bleeding stroke. So I'm worried that it might do more harm than good.
So Jeff and Mintu, what would you do next in a situation like this? Do you have any particular recommendations that primary care clinicians should keep in mind?
And so, Jeff, I think this is a great example of what we've worked on our previous segments with Dr. Tarakji and Dr. Ruff, and now getting into the details about the issues of when to start anticoagulation and what it means. You've done so much here, but this is a common scenario. Why am I taking a medicine that might hurt me when I can't even feel whatever it is you're telling me I have? You know, with blood pressure medicines, the safety profiles are a little bit different. There isn't this sort of an imminent fear of bleeding like you might think of with anticoagulants. So how should we think about this in these situations, particularly in a remote encounter environment?
Yeah, I think that's such a great question. And I get this all the time when I talk to patients. They tell me they can't feel their AFib, so why are they taking a pill? And I use the exact example that you just highlighted there, which is you can't feel your blood pressure most of the time anyway, but you still take a blood pressure medicine because you know how important it is to keep that under control. In the same way, you may not always feel AFib, but you have to take this blood thinner if you want to try and prevent a stroke. I really try and help my patients understand that many medicines we take are preventative, things like blood pressure pills and blood thinners or anticoagulants, while others are to treat specific conditions, something like an antibiotic maybe for an infection or something like that. But it's so important that they understand why they're taking it and what the goal is of using that medication.
Thank you so much, Jeff. Let's watch the next part of the visit where I used an anticoagulation choice decision aid to help address her concerns. We have tools to help weigh your stroke risk against the bleeding risk to decide if a blood thinner is more likely to be helpful. In your case, being on a blood thinner is a safer option than not being on a blood thinner.
Okay, but knowing that taking this drug is increasing my bleeding risk, are there any things I should be doing to try to prevent the bleeding? And what if the flutter goes away? Do I still need to stay on it?
I hear that you're concerned about minimizing your risk of bleeding. Yes, it is a risk, but here, let me show you something that will visualize how the bleeding risk compares to the stroke risk if you don't take the blood thinner. I'm going to try to share my screen. You let me know if you're going to be able to see it.
Yes, I can see it.
Great. So I'm going to put your information here. So we know you're a female and you're 67 and you've got blood pressure, but you don't have heart failure or stroke or diabetes or any of these other things. And so when you put all the information into the calculator, you can see that if you were to take 100 people who had risk factors that were like yours, who were not taking a blood thinner, over the course of the next 5 years, 6 of them would have a fatal or disabling stroke. Those are the people in purple. 11 of them would have a stroke. It just wouldn't be disabling or non-disabling stroke. And 83 of them would have no stroke at all. But now if you compare that to people who are actually taking a blood thinner, so they're on anticoagulation, the blue dots show you how many strokes are prevented by the blood thinner. So 12 people will be prevented from having that stroke, but only one person will end up having a fatal or disabling stroke.
Okay, I can see that blood thinners prevent strokes, but what about bleeding?
Oh, that's a good question. So if we look, this tool has something about that too. So if we come and look under these issues, they have a whole part about talking about bleeding. And if you look for an average risk person, so this one doesn't really go by your number specific, for an average risk person, it is possible for a person to have more bleeding if they're on a blood thinner. But I got to tell you, the truth is that if we were trying to think about for you, we would actually calculate a more specific number, something called a has blood score. And it goes through the same types of risk factors. And if a person has, say, 1 or 2 risk factors, like for you, you're over age 65 and you have high blood pressure, but your blood pressure is pretty well controlled by your current medicines, we wouldn't even give you a point for the blood pressure. I mean, the last time we checked, your blood pressure was like 145 to 150. It's still hanging in there, right?
That's right.
Right. So we wouldn't even need to give you a point for that. So with 1 point for your score, your bleeding risk would be really low. And so that would mean being on the blood thinner is a much safer risk than the risk of stroke. And so I just think that it really makes a lot more sense for us to have you on the blood thinner.
Okay, I get it. But if I have to be on a blood thinner, is there a way to make it as safe as possible, like maybe a lower dose?
Well, we do want to make sure we're on a dose that actually gives you the benefits of stroke prevention, but we do have a few different drugs to choose between. So 3 of the 4 have a reversal agent. So if God forbid you do end up in the emergency room with a bleed, like we can certainly give you a medication that will counteract the blood thinner and stop the bleeding. And then among those 3, one of them has actually been shown to have a slightly lower bleeding risk than the other ones, but has the same effectiveness at preventing strokes. So that one may be the best choice for you.
Yes, let's go with that one.
Now, that one does have to be taken twice a day. Do you think you're going to be able to remember to take it twice a day, every day?
Yes, I already have other pills that I take in the morning and the evening. Plus,
Okay.
I have my watch to remind me.
Okay, good. So I need you to remember that you're going to take it every day, even if you don't feel the heart flutters. Jeff and Mintu, how do you approach shared decision-making with patients who have concerns like Mrs. Carter's? Do you have any feedback for me on anything I should have done differently or that you would have recommended I do?
And again, such a great real world scenario. And what I really love that this virtual encounter illustrates is walking through, and in this case, having a screen that you're looking at and that your patient's looking at together is almost easier than trying to do it in a clinic office. And so this is one potential advantage to a virtual visit. A little harder with phone only, but the same principles would apply. And Jeff, in part 2 with Dr. Ruff, we did emphasize that HasBlood is really a framework, but given its limitations, the formal use of it has really been discounted and not been recommended, I should say, for some time. But given that it identifies a few potential areas of increased bleeding risk, weighed against the potential risk of stroke, how do you think through the use of a shared decision-making tool to help and not further confuse a patient?
Yeah, that's a really great question. And I think you have to think about what's the purpose of using the tool when you're having that conversation. You know, I find that so often doctors don't realize that they're giving just an overwhelming amount of information to patients. So when you use a shared decision-making tool, it can help you focus on the most important pieces of information and help you communicate that in a way that's really easy for a patient to understand. For instance, I saw you using that icon array so that you could visually represent risk rather than just presenting percentages or numbers, which many patients may not understand. The other thing that the tool did, and I loved how you did this really well, is you used the tool to help identify what the patient's concerns were. So that way you could understand what was most important to her and answer a question, because now she's going to be your partner in choosing to take that medication. And that's likely going to help her be more adherent to actually using her anticoagulant. And we hope to prevent any sort of a stroke or other complication.
That's really well said. And actually, you just gave a great prelude to your own set of slides coming up. And we're going to turn over to Dr. Barnes, who's going to really talk about shared decision-making in the context of stroke prevention. Jeff, take it away.
Thanks so much. You know, when we think about shared decision-making, it's important to think about what that means. And I think this figure here, for me, really highlights shared decision-making is about the exchange of information in two directions. It's not just the physician or the clinician telling the patient something, but it's also learning important information from the patient. Maybe it's about their values or their preferences for different types of therapies or conditions. And so that information has to be given in two ways. And when that happens, you can come to a decision together about whatever it is you're trying to choose. In this case, it might be about taking an anticoagulant or picking which anticoagulant to take. Now, it's important to remember that shared decision-making has a couple of key components. It always involves two or more parties. It might be 3 or 4 if you have other family members or maybe other clinician groups involved. And that information is always shared back and forth. There's education, there's reviewing the values and preferences, and that the decision is something that you come together and agree on as a group. But I also want to highlight what shared decision-making isn't. It's not simply using a risk tool like the CHADS VAS score or the HAS-BLOOD score that we've heard about and simply showing what those numbers are. That's very one-directional. And so it has to be more than just the education. You really have to ask questions and learn about your patient and what's important to them to have that two-way conversation. We know that there are a number of important benefits when you engage in shared decision-making. Our patients have improved knowledge. They know more about their condition, they know more about their treatments, and it really improves both their satisfaction and it even improves provider satisfaction. Many clinicians feel better about the conversation in the visit when they use some sort of a shared decision-making tool and engage in shared decision-making. It also can just decrease something we call decisional conflict or uncertainty. Basically, patients are more certain and more confident in the decision they make for treatment. In this case, it might be about choosing to take an anticoagulant to prevent stroke. It also can sometimes even reduce unnecessary tests or procedures if patients know exactly why they don't need that test or the procedure. And it's important to point out that when we ask physicians about how much discussion, how much two-way conversation happens in a clinic visit, they usually overestimate that significantly. And so when you actually record them, or if you ask a patient, they'll often report much lower rates of conversation. They feel like they're being talked at a whole lot. So by using a shared decision-making tool, it facilitates more of that conversation together and rather less of that lecturing to that sometimes we as physicians just have a tendency to do. There's actually quite a bit of evidence for shared decision-making in atrial fibrillation specifically. In fact, there was this one randomized trial that was recently done where they randomized over 900 patients who had atrial fibrillation, including almost 250 clinicians. Some of them got to use this decision aid to really help their shared decision-making conversation, and others just had a regular standard clinic visit like we normally would. And they assessed different qualities of the decision-making process, like the communication, they assessed the patient knowledge, they even asked the patient how accurately they could estimate their own stroke risk and things like that. And what they found from this pretty large study is that clinician satisfaction was higher when they were able to use the decision aid. The patient became more involved in the conversation, and they actually had video assessments of those clinic visits to be able to quantify that. The patients had less decisional conflict. They felt better about their actual decision making. And I think this is really important for clinicians to know. The visit duration was almost identical, 32 minutes versus 31 minutes. So when you use a tool like this, it doesn't necessarily have to prolong your visit. In fact, it may even help make it a little bit more efficient. Now, they did not show any difference in sort of the actual decision that the patient made as far as whether or not to be on an anticoagulant. But overall, it was probably a higher quality visit that everyone felt really good about. And so I think that's an important set of data to really support why we use shared decision-making for our patients with atrial fibrillation. It's also really important to understand some of the barriers that we're currently experiencing for our patients with AFib. We know that less than half of all high-risk patients with AFib are actually receiving anticoagulation, and therefore they're at high risk for stroke. And even those who we do get to start their anticoagulant, as many as 50%, as many as 1 in 2 will stop their treatment at some point in that first year, meaning that they're then unprotected against stroke. And so the guidelines have really told us that we need to try and do shared decision-making whenever possible. In fact, the guidelines from the American Heart Association, American College of Cardiology, and Heart Rhythm Society in 2019 said that shared decision-making can improve adherence to anticoagulant therapy. And so it's a strongly recommended practice. That's not just from the American guidelines, but it's also recommended in the European guidelines as well. Use shared decision-making to come to that clinical decision together. I think it's really important. This is strongly endorsed by guideline societies, really on both sides of the Atlantic. Now, there are a couple strategies that I think can help you use shared decision-making in the most effective way possible. First, know when it's important and it's appropriate to use shared decision-making. This is not something you should use for every single clinical decision. It's really best for what I call preference-sensitive decisions. Things where there's more than one right answer. It's important to understand what's right for the individual patient. So if there's a case where it is clear-cut what we should do, all the evidence tells us we absolutely should do this one thing, that may not be the best opportunity for shared decision-making. But when there's opportunities for multiple right answers, that's a great place to use it. So in the case of atrial fibrillation, if somebody has a really high CHADS VAS score, so they're at very high risk for stroke, we know that the right answer for them is to take an anticoagulant. That's an opportunity for education. However, there might be different anticoagulants that could be appropriate, and depending on the patient's preferences, values, and their situation, we may be able to figure out what's going to be best for them. That's really an ideal situation to use shared decision-making in a decision aid. And so to get at that, it's really important to ask the patient about their values, their preferences, and their priorities. I use phrases like, well, what's your most important goal? Or are you more concerned about this or that? So I might say, are you more concerned about having a stroke or having a bleeding incident that leads to a hospitalization? Because once I know what's important to the patient, then we can talk about how the different therapies may help to move in one direction or another. The other thing we know is that numbers can be really hard for people to understand. And so it's really helpful to use a decision aid that's built in a visual representation of those numbers. The one that was shown in the clinic visit here used this really nice icon array. So you can visually see the purple circles and the orange circles and how they change to blue. And it becomes an easy way to understand rather than simply saying, well, 5% have this risk and that changes to 2%. Those numbers can be hard for people to understand. Sometimes we like to use relative risks. We talk about things being 20% lower relative risk. I often will use a coupon analogy for my patients. And I say, it's kind of like shopping with a 20% off coupon or a 40% off coupon, because that's something that they can really relate to and understand. And so trying to make numbers as accessible as possible is a great strategy for facilitating shared decision-making. Now, telehealth, I think, presents some really interesting and unique opportunities to overcome certain barriers that we experience when we try to help our patients who have atrial fibrillation. You know, for many patients, simply traveling to a clinician's office is a major barrier. I mean, think about our older patients. They may not drive. It can be difficult to get out. I live in Michigan, and so in the winter months, we have bad weather. It can be even more dangerous for those elderly patients to get out. And of course, these are the patients who are at most risk of AFib and AFib-related complications. There are also patients who live in rural areas. They may be farther away from the clinic. They may have income limitations that prevent them from getting to clinic, and simply time constraints. People have jobs and families and other things like that. It's much easier for them to use a telehealth visit. And so we really need to think about how we can leverage this technology to help get our patients the care they need and overcome some of those barriers. Now, at the same time, I want to be careful. Telehealth is not the panacea. And we know that not only are there disparities in AFib care in general, but there are also some disparities in how telehealth can be used by our patients. In fact, there was some data from 40,000 clinic encounters in New York, which really highlighted this point. We know that racial disparities exist not just in the care patients receive, but in how they get their care. And so some patients, Black patients in particular, were far more likely to use an emergency department rather than a clinic visit when they had different opportunities. Similar disparities exist for some of our Hispanic patients, where they're more likely to go to the ER or use the clinic rather than using telehealth services. And there's a whole host of reasons why that's the case. As individual clinicians, I think we can make some small inroads to try our best to make these services available for patients, but these are really system level challenges that are going to require some system and population level solutions. We can also just remember that not all of our patients have access to broadband or easy access to Wi-Fi, and many of our older patients don't have great use of smartphones or computers with videos. And so we need to be as flexible and adaptive as possible to try and make sure that every patient has access to high quality care. So quickly, just to summarize this piece, shared decision-making, it is a two-way conversation. We need to ask questions, we need to listen, and we need to learn from our patients because they have a lot to share with us. When we do that, then I think we have a real opportunity to engage them as a partner in their clinical decision-making and in their clinical care. Also, shared decision-making is not appropriate for every clinical situation. Think about when you can use it, those preference-sensitive decisions, when you have a really interested and invested patient and maybe even some family that can help to support that. And think about using technology. How can we leverage technology and telehealth to our benefit? I love the way in the clinic visit, you were able to pull up the decision aid and actually look at the screen together. That's such a great tool that may not be as easy to do perhaps in a face-to-face, but becomes really easy when we're doing a telehealth visit. So think about how we can do that, how we can share screen, how we can get family members involved who may not always be present in a physical clinic room, but we might be able to access if we're doing the telehealth visits at home. So lots of great opportunities to use telehealth to improve care for patients with atrial fibrillation.
Jeff, thank you. That was a wonderful talk, very enriching and so much to discuss. And there's a lot of, we can dive right in and have a little discussion here before we close out. I want to emphasize some of the points that you mentioned as a launch point for what we can talk about. One, obviously, is, as you said time and time again, SDM is a conversation. It's not just using a risk score on your computer. And the other point is it's really not just about a decision of when to start therapy, but the calculus continues every time they're up for a refill, and persistence on therapy becomes important, especially in light of what we heard on our second segment with Dr. Ruff. This is an indefinite therapy until we have better trials. And this coupon analogy you mentioned is just great. Some of the challenges, of course, and that's what I want to get into, is the tension and difficulty that can vary based on the setting of care. So I think, Jeff, you and I have it easy. I have it easiest. By the time they see me in electrophysiology, they're already committed to therapy. But as a primary care doctor, Margaret, you are negotiating with not just a fib. This is one of potentially many issues in their life, whether it's medical, mental health, so many things, right? And so you almost end up brokering, negotiating a lot back and forth. And I want to start there. Like, how, we think of shared decision making kind of as an individual, discrete, let's talk about your AFib. Obviously, an end of life, there's more complicating issues, but in the middle of life, people can have a lot of medical issues. And how do you think through or advise clinicians to go through these issues and broker or prioritize them with your patients?
So for me, the way that I tend to like to think about it is that you're always doing shared decision making, but sometimes you go into more depth than others. So that if you set up sort of an environment that expects questions and one that welcomes the discussion, then you may find that sometimes you need to have more discussion and sometimes you need less discussion, but there's always some discussion, so that you're always having this sort of dialogue back and forth about the risk, about the concerns, about what they're excited about, what they're worried about, and it makes the entire discussion just easier. And so I find that a lot easier. And one of the things that Jeff said more than once, and I think really needs to be highlighted, is just that bidirectionality. So the idea that this isn't you figuring out another way to lecture in a new fancy snazzy way with new tools. So yes, there's some of that that's involved. So for example, you do have to get the data across at some point in some way, shape, or form so they understand what you're trying to say. But I find most of the time that's not where the patients are hung up. So it wasn't so much the numbers that they wanted to know more about, it was the context of the numbers. And that context was very much related to their own personal life. So if you hadn't done the work ahead of time to actually listen and to hear or elicit from them what they're really worried about or what they're genuinely concerned about, then you could spend the next 20 minutes talking about numbers with all the fancy tools in the world and still get nowhere, because you never really addressed my number one fear, my number one concern. And often those aren't concerns that are only limited to one disease state or one medication. It's usually a pattern of things. Like if I have a concern about taking medicines and side effects, that usually relates to my blood pressure medicine, my diabetes medicine, and now this new AFib medicine. So if I know that about you, I start from, I know you normally have worries about medicine. Let's talk about that now. So like, I know you're going to be worried about it. Tell me what you're worried about now. So we can just sort of open that discussion and dialogue up from the beginning. So I think that's critically important, and that you're using the tools for what they're designed for and not for sort of taking over the discussion from the physician side, but really for engaging the patient and understanding and helping them to move themselves along on the decision that they're making. Because ultimately it's their decision to make. You just want to help them make it feeling educated and confident in what they're deciding to do.
I love that point. And it makes me think back to when I was in training, one of my mentors told me, open every clinic visit with a question, right? Because start with that. Start with the perception that you as the physician are here to learn about the patient, right? And sometimes it's what's most important for you to discuss with me today? Because if I know what's most important for the patient and I can address that, they might be more open and receptive to whatever I think is really important from their clinical side. And it sort of normalizes that conversation. So I agree 100%. Start out with a question, start out by listening, and then that'll open the opportunity to really let the rest of the visit unfold.
That's a great point. And I think it also underscores how even if patients are very different, what's deeply rooted in their concerns can be the same. But how you might approach it in the decision-making might be different. And I'll give you kind of an extreme example. I mean, there might be, one patient is like, hey, doc, I'm just going to do whatever you say. And they still could be terrified that you're telling them to take an anticoagulant. They're just not going to tell you. And then, I'm at Stanford, like across in the middle of Silicon Valley. Well, I'll have patients who bring their entire genome sequence on a USB drive and say that I've identified 15 variants of unknown significance that might increase bleeding risk. So the issue really is going to be, what do you do about that? And how do you tailor shared decision making, Jeff?
Yeah, I think that's a really great question. And so the first thing I would say is you have to remember that not every patient wants to participate in their decision-making process, right? So that first patient that you told me, that's somebody who really wants me to give them some pretty strong guidance. So I'm going to try and ask a few questions, but if I'm hearing early on they want me to tell them what to do, then I'm going to sort of explain to them my best advice. However, that second patient is really coming armed with a lot of information. And what I find sometimes when I get overwhelmed with information, or maybe information that I don't always know what to do with, I try to understand why are they bringing that forth. And so what I heard you describe for me is somebody who's bringing forward a lot of information about their own genome because they want to make sure they're not going to have a bleeding problem, or they want to know that this is the best drug for them. So if I can figure that out, then I can sort of move through that heavy bit of data to really get at that main point and say, okay, what I'm hearing you say is that you're really concerned about potential bleeding complications. So you want to find the drug that's going to minimize bleeding while still giving you stroke prevention. Is that right? And then that lets me get back to sort of my normal cadence with how I talk about anticoagulant choice for AFib.
I think that's great, because what you see is often the response. The stonewalling or heavy intellectualization is still deeply rooted in the same concern. So this is great advice to hear from both of you. And then the last major topic I want to touch on, and we can spend some time on this, is the issue of equity and the digital divide. So there's barriers to cost, there's barriers to access, refill compliance. People may not be able to pick up their refills. You know, not everyone is going to have mail order services. And so all of these things come into play. The other one I'm just going to add to this is, you know, there's been a lot on the digital divide and how it's affected healthcare in COVID. We talked earlier about access to smartwatches and internet and issues around equity, but I'm wondering about how this fits into the framework of shared decision-making, both starting with culturally appropriate tools, thinking through health literacy. I mean, is it going to work if I get someone, you know, with sort of more limited health literacy to sort of even see the graphical representations? And so how should we be thinking of this? How do you tailor the discussions and the decision-making, Margot, across a wide range of patients from a wide range of backgrounds?
So for me, this is one of those times where I think that the data is always interesting to me, but there's usually another story that's happening behind it. So for example, I practice in North Philadelphia. So, you know, I wouldn't have thought we would have had broadband issues because it's a major city. And yet we did have people who couldn't access their telemedicine. They couldn't get through the portal. They couldn't figure out how to do things. It wasn't necessarily age related. It wasn't even necessarily income related. Some of it was just literally access. They just didn't have the ability for the service to work well where they live, or they just didn't have access to the devices to be able to be reliable enough for us to hold a whole video visit without having a lot of challenges. What I find interesting though is that, for example, some of the conversations that people raise aren't always racial, but they come across looking racial. So for example, oftentimes people were describing to me how Black and brown patients tended to go to the emergency room or the urgent care, even in the middle of COVID, even when everybody was getting sick. And why didn't they know to just pick up the phone and like do a phone call? And what I found is that if you ask the people, so you just ask them, so why did you go to the emergency room instead of doing the phone call? Some of it was access that was limited by us. So for example, they had to go to work. And so going to work was still a priority. They couldn't just not be at work. And if you wanted them to pay for the medicine that you set for, that isn't always the most reasonable price for them. They needed to be at work and they didn't have the days to take off. So the only thing that was available by the time that they were free to be able to access their care was the urgent care or the emergency room. So that you started to have a mixed picture of people where you were characterizing groups of people in ways that looked like it might have been because of one thing, but really it was a correlation and not a causation, and that there may be some other stuff going on in there. And so I just honestly start with asking patients. I've just gotten past the part of trying to guess what's going on and just asking them up front. So if they didn't get the refill, I just asked them if there's a reason why. Sometimes it's something as silly as I just didn't get around to it. And other times it's something, you know, really complex and I have to figure out, you know, do I need to figure out, you know, a new insurance plan program or a prescription drug management type issue, or do we need to, did the formulary just change and you didn't know because it was January? And that happens to a lot of people every year. Come January, the formulary just changes and suddenly they have a problem. And so it's just much easier to just start with asking the patient and being open to the answer. I think that honestly, you can find a lot of solutions that seem like they would be impossible, where the disparities are so great and that you couldn't possibly fix it. And it turns out that they're not always as complicated as we think they are.
Well said. And Jeff, I'm going to turn it over to you, sort of your final thoughts on this really important issue.
Yeah, I think this is a really important topic. And this is one area where telemedicine has sort of offered two sides of a sword, so to speak, right? It has actually increased access for many people, but in other ways, it's sort of limited. And I think you highlighted those so nice, Margot. One thing we've done at our center is we've begun to offer after hours visits. You know, as a physician, I no longer have to be in the clinic. I don't have to have a medical assistant and a nurse with me, but I can do a visit at different times of day. And so we've addressed some of those concerns, but I think there's a lot more at a system level we need to do. Individually, the other thing I heard you talk about that I hear all the time is when patients aren't the most compliant or they don't follow the rules, sometimes we jump right to the judgment phase. And I really think that we as clinicians have to ask in a really honest and open way. So help me understand how we got here. And one of the things I do is I try to normalize not following the rules. So in the case of the anticoagulants for AFib, I tell every patient I'm starting them on. Now, I know that for many patients, these can be really expensive and you just won't know until you show up at the pharmacy. So if this is going to cost more than $25 or $50 a month, and that's not something that you think is appropriate, then give me a call and we'll come up with another solution. Because as soon as I normalize that for them, I take a little bit of that sort of stigma or fear away. It's not fully gone, but I've opened the door to tell them that it's okay for them to let me know they can't afford it. I'm not going to judge them. I'm going to work with them to try and come up with a different solution. So I think some of those small tricks we as clinicians can use to try and just make it a little bit easier for our patients to get the therapies and the care they need.
Yeah, and that human element is just so important. I mean, you know, having AFib in some ways does kind of suck, but that's why we're here. And that's why we have treatments, right? If it would suck even more if you couldn't treat it. And that's why, you know, I, like Jeff and you, Marco, are committed to really giving great care around AFib. That's what we do because, you know, we have ways to detect, we have ways to risk stratify, and they're going to get better. We have ways to treat. These drugs are safe. You don't bleed as much from back in the days where the stroke rates on poorly controlled warfarin with uncontrolled hypertension were so high, or people were on, you know, an antiplatelet agent plus aspirin plus, you know, an anticoagulant. I mean, we've just learned so much. And I think that's the positive that I try to convey to my patients as well is, you know, what's the counterfactual here? And then I think it can really, really help them if they see that. I think we're going to wrap up now. That was a really fantastic discussion. And what we'll do in our wrap up is review our SMART goals that we hope you can carry into your practice. So these are the specific, measurable, attainable, relevant, and timely goals. And today really was all about shared decision-making through the lens of telehealth. Ask patients what questions they have. Remember, this is a conversation, as you heard Dr. Barnes say over and over. Counsel them on the risks and benefits of treatment options. Use the tools, share the screen when you can, as you saw Dr. Savoy do. Come up with a treatment plan that your patients regard as thoughtful and individualized, because it is. That's what risk stratification is. You want to reinforce the importance of adherence, taking it when you're supposed to, and persistence, staying on it if you're supposed to. And again, maintain electronic or other resources to provide for patients. There are many that are also culturally appropriate that are available. If you have any questions or comments today, you can share them with us on Twitter using our hashtag. You can also follow CME Outfitters or any of us on Twitter, and you'll learn from CME Outfitters about upcoming activities. You can visit their cardiology hub on their website for other activities, and also see the other two cases that preceded this. And finally, to get CME or CE credit, you can go to the evaluations tab on the website. I really, first and foremost, want to thank Dr. Savoy and Dr. Barnes for their fantastic discussion and insight today. I learned a lot. I hope you all did too. Thank you again to our audience for joining us. We hope you learned a ton here that you can take with you.